Good afternoon, everyone. Welcome to an oral abstract presentation. So today we're going to talk about diversities in delivery prep from home to clinic. So my name is Rina Janamnoysuk. I'm from the Thai Red Cross AIDS Research Center based in Bangkok, Thailand. And I'm going to co-chair this session with Edward Sender. He's from Kemri Welcome Trust from Kenya. So it's our pleasure to have you all here in late afternoon. So please start with the first presentation from Musa Sar. He's going to talk about retention in care for HIV pre-exposure prophylaxis among sex workers of 4 public health centers in Senegal. Welcome, Musa.
Good afternoon, everybody. Okay. So I'll be talking about the retention in care for HIV pre-exposure prophylaxis among sex workers in 4 public health centers in Senegal. This is one of the demonstration studies sponsored by the Gates Foundation in Kenya, India, South Africa, Nigeria, Benin, Senegal, and Mozambique. And a little reminder of the geographic location of Senegal in West Africa. As a background, Senegal has experienced a long success on HIV control, maintaining HIV prevalence below 1% in the general population. However, the prevalence among groups such as female sex workers and MSMs remained very high. This explains the reason why the National Public Health Program provides AIDS education and teaches risk reduction skills through one-on-one sessions or small groups. And there's a need to move beyond the existing type of interventions such as community level and structural level prevention type of programs, and now also adding biomedical interventions to help lower HIV incidence among sex workers. Recent breakthrough in antiretroviral-based prevention, as we all know, PrEP recently has provided a new opportunity to rethink HIV prevention strategies, especially for key populations such as female sex workers. As PrEP demonstration studies are increasingly initiated and now moving beyond the clinical control environments to public health centers or community level, so there's more information needed about the correlates of PrEP retention when implemented in Ministry of Health run clinics in Senegal. This is within the context of regulated sex work, where female sex workers can register within the system and, for example, have monthly HIV, STI visits in the MOH-run clinics. We also enrolled unregistered sex workers because we believe that they will also benefit from receiving PrEP. Overall, beside the screening, we did a baseline assessment 7 days, 1, 3, 6, 9, and 12 months. Provided Truvada for PrEP at day 0, month 1, and then every 3 months thereafter. Measures, we did sociodemographic measures, medical history, physical exam, lab tests, and a series of behavioral assessments. Description of the population, the mean age was 38, the minimum was 18, maximum 57. Most of the sex workers were registered in the system at 63.7%. But we also had a sizable number of unregistered sex workers at 36%. 98% of the participants were Senegalese. 41% never went to school. And among those who went to school, half, 49.8%, only went to primary school. Overall, we screened 350 in the 4 centers. Out of the 350 screened, 324 were eligible. And among the 324 eligible, 57 declined, and 267 accepted to enroll, which gave us an overall uptake of 82.4%. So if we look at here, we have 267 enrolled. Out of those, we had 77% retention rate at month 3, 70% at month 6, and 67 at month 12. We did also some adjustments because at the beginning, discontinuation so these numbers include all discontinuations. But if we take into account the fact that there was some reasons for discontinuation that were not related to the program, such as move to another region. So those who moved to another region, if the program was available in the entire country, they could have been referred to another center instead of being discontinued. Pregnancy also, when we started the study, there was kind of a blurry, it was kind of not sure what to do with those who were pregnant. So we had a second consent form and allowed the participants to consent to continue or not when they're pregnant, and many of them choose not to continue. These are the Kaplan-Meier curves of retention. So we can see here the curve without the adjustment for those reasons of discontinuation, such as death, pregnancy, and moving out of the area. And then here with the adjustment. So if we adjust, the 1 year retention at 12 months was 74.5%, and without the adjustment, 67% at 12 months. For the predictors of retention, overall, we can, the take-home message is that the only factor that was significantly related with retention was age. So all the age was related to higher retention overall. There was no significant difference by site, by education, by registration status, condom use, or HIV risk perception. This presentation is focused on retention, but it's PrEP, so we have to also say at least a word on adherence. This is the adherence curve using MEMSCAPs. Overall, it fluctuates between 50 and 60%, not taking into account the fact that even though we pushed for daily PrEP, participants practically took PrEP when they felt at risk. So when they were at home in vacation with grandma and not practicing sex work, they didn't take PrEP, even though we pushed for it. Other findings, there are no incidents of HIV during the 12-month follow-up. As mentioned again, despite the recommendation for daily PrEP, most participants did not take the meds when they did not feel at risk. The top reason for non-adherence were simply forgot, were too busy for other things, and ran out of pills. Very quickly, the barriers and facilitators at individual level: fear of stigma, medication, daily intake, size, color, blood test, the fact of taking the blood test at every quarterly visit. Hopefully, during the K-Lab, it will be semi-annually, it will be like a LIDAR. Mobility, younger age, facilitators, counseling group, and individual, the provision of free STI treatment, provision of condoms, and having younger peer educators. So on the social level, the major barrier was the stigmatization at family and community level, a structural lack of coordination between different sectors of the health center, the midwife, the pharmacy, the lab. Usually it was, we had to kind of provide some help, training, and SOPs to have that more fluid. Workload, lack of research experience, even operational, mobility of site staff, and just the overall capability of the site and the lab. In conclusion, our results show evidence of good PrEP retention among female sex workers at 12 months follow-up when offered in Ministry of Health-run clinics in Dakar, Senegal. Older age was the only significant predictor of higher PrEP retention. Acknowledgement to our sponsors, the Gates Foundation and Gilead, who offered free drugs, the study participants, peer educators, all stat staff, and our colleagues. Thank you very much.
So this paper is now open for questions. Could you briefly introduce yourself?
Hi, I'm Nancy Padian from Berkeley. I was going to ask you, given the fact that age was the only predictor, I mean, it's sort of hard to imagine what to do and how to fix that. But on the other hand, when you looked at your barriers, there were many things that were barriers that didn't have anything to do with age, like stigma, lack of coordination. So were the barriers that you found as risks to retention in the study? And again, I thought you just said age, or is it more hypothetical? And all of this is geared towards what can we do to make implementation better so that there's better uptake?
Absolutely. Yes, I mean, the fact that age came out as the only predictor was what we found when we did the data analysis. Mm-hmm. But we have operational issues because some of these. We have a paper that's going to come out that will be focusing most on operational issues. For example, the stigma. When at the beginning when women come to the clinics and so the site staff were not very well trained, they had to wait for a long time, and some of them didn't feel that very welcome, and and even though the numbers were not that high, but some of them, that experience may not come back to the clinics. Mm-hmm.
But you measured stigma as in association with retention. We didn't have a strong measure of stigma. Oh, I see. Okay.
Yes.
Thank you. Joseph Larmarange for the French Research Institute for Sustainable Development. Thank you for your presentation. You mentioned at some point that some women stopped because we were pregnant. I would like to know, practically, did you propose contraception within PrEP? Was it free for the women? And do you have some information about uptake of contraception? Because PrEP is not protective for pregnancy. And my second question is, if I'm right, in West Africa, hepatitis B virus is quite prevalent. And now, when moving, from efficacy trials to implementation, how did you manage women with hepatitis B virus? Because if we start to provide free of charge PrEP for prevention, while the same drug, tenofovir, is not available for people in need for their hepatitis, it will create, just some inequity in access to care.
Absolutely. Yes. For your first question about pregnancy, when we started, it was kind of really a blurry area. There was no strong recommendation about PrEP. Right now, it's very clear. PrEP is not. There's no reason to exclude a participant because they're pregnant on PrEP. But when we started, it was not that clear. So we had a second consent form, to allow women who become pregnant to be able to be informed about potential risks and make an informed decision if they want to stay or not. Yeah, so not sure if that answered your question about that. Do
you have uptake of contraception within the program?
We didn't provide specifically contraception. We collected information on contraception. We pushed for contraception, in fact, for those who. But we wanted this to be real life. We didn't want it to be a controlled clinical trial where everybody is not on contraceptive. If you're not taking a contraceptive, you're out. So we provide counseling, but we wanted to have this be a real life kind of issue study. For the hepatitis B, we tested for hepatitis B at the beginning, and for those who were positive, we tested the titers, the viral load, and followed for that to see if they were at the point where there was a need of treatment or not. And those who needed treatment were referred to the national program.
Musa, I have one question, maybe allowed as chair. There is a substantial epidemic of in MSM in Senegal. Mm-hmm. Some may also be sex workers. Were they allowed to actually start PrEP, or are they not recognized by your program?
Is an epidemic of
HIV in men who have sex with men in Senegal?
Yes. Yes, and I mean, this is the discussions that we are going to have with the Ministry of Health. Because definitely, I mean, the two groups that really mostly need PrEP right now in Senegal is female sex workers and MSM. So we are right now in the discussion to see if we're going to just do another demonstration study or just completely focus on a scale-up, but starting slower and maybe with some sites with MSMs, and then get more information before we go full-blown scale-up with the group. But definitely, there's discussions about it, and there's a need definitely for the group.
Yes, thank you very much, Musa. Thank you. So let's move to our next presenter, Ms. Ravipa Wannakit. She's going to talk about key population-led health services, KPLHS, critical to PrEP introduction among men who have sex with men and transgender women in Thailand. Ravipa.
Good afternoon, everyone. How's life in Amsterdam? Beautiful, isn't it? I lost my iPad in a cab today and it was returned. So it's really, thank you, Amsterdam, thank you, people. So I'm presenting to you today about key population-led health services for delivering PrEP. So this is another service delivery approach that we would like to share with you. This experience from Thailand. So the background is that Thailand is one of the other countries that experiences concentrated epidemic among key populations, and MSM, the infection among MSM account for about more than 50% of new infections in the country. And so therefore, MSM and TG populations are really our prime focus for PrEP scale-up. The development around PrEP provision, PrEP availability, and implementation in Thailand started in 2010, so almost 10 years ago, started by the country involving in some of the prominent research studies, including IPREX, as well as HPTN 052, and then followed by initiative from the Thai Red Cross AIDS Research Center, of course, starting the first test and treat project among MSM and TG women in 4 provinces in the country. 4 years after the first initiative, first research study, then Thailand started to develop national guidelines on PrEP provision. Again, Thai Red Cross initiated PrEP 30, which means that the clients pay $1 a day for PrEP at their clinic, anonymous clinic in Bangkok. The point here is the turning point is May 2015, when we, PEPFAR, supported USAID linkages to initiate the committee-based, committee-led test and treat program, looking at the feasibility of this approach in implementing test and start in Thailand in 4 provinces. So prior to this, in 2000, I remember in 2000, around 2012, 2015, between then, we were able to test around 600 people a year, key populations. I'm from USAID. And we looked at the number. It was already challenging in order to reach that number. And when we did the key population implementation science led by Thai Red Cross, the number that we did not expect to have, it went up to 6,000. We were surprised. We were shocked But then we realized we are at the right place. We were doing the right thing. It's the right approach for it. Community-led it is. Taking it further, we intensified the approaches with FHI 360, USAID linkages, and Thai Red Cross. The leadership of the Thai Red Cross, I think he was on the plane and thinking, Thailand must have PrEP available for Thai people, and how do we do that? PEPFAR cannot fund it. Then he wrote a small proposal asking the princess, Som Savali, to provide support and generously so. She gave a grant for these to be used for to use public donation under her patronage to provide PrEP for 1,000 cases per year, and that is part of the Princess PrEP program led by Thai Red Cross. Yes, don't be shy. So focusing on the key population-led health services approach now. So this approach has been implemented by the key population-led community-based organizations. So these organizations previously, they conducted only outreach interventions. They have been now trained to do everything, starting from STI screening, HIV counseling, testing, PrEP provision included. Same-day ART is coming out. So with this approach intensified with the delivery of the KP-led organizations, there are a number of technologies, innovations, and optimization approaches placed with them in their hands, including enhanced peer mobilization, or EPM, which helps to strategize the way they can reach more people, hidden population, using themselves as friends, talking to friends. It also involves community-based HIV testing and same-day ART, as I mentioned. That also includes oral fluid screening as a pilot study, because in Thailand, we still have to do it under research in order to showcase that it's feasible, it can be done by key populations, and it can help increase uptake. And hopefully that will inform self-testing in the very near future. And then PrEP. So these community-based organizations now, they are key population-led fully. And they are our active partners, not only to implement programs, but also to help to conduct research. They have now got the capacity that, and one day we can help to use this to mobilize or to diversify resources for them to be sustained, either being a research site for NIH in future. We are hoping that might happen. It is happening partially. So this is really a summary of where we are in Thailand by June 2018. PrEP delivery, PrEP provision is available through PEPFAR support, mainly under the Key Population Implementation Science through CDC Thailand and USAID linkages program, Thai Red Cross. What I haven't mentioned is that there might be, and we believe there are a number of PrEP users that are using the services at the private clinics, private hospitals. So we call fee-for-service PrEP, and this number haven't really been fully accounted in the national HIV databases. And then we have the current project, Key Population-Led PrEP, Princess PrEP, under the USAID linkages program in Thai Red Cross in currently 4 target provinces, but expanding very quickly to 9 provinces in Thailand. So the data from our recent program suggests this is the right approach. We are reaching the people who are at highest risk. We see the MSM and TG who are having group sex or have been engaged in drug use and chemsex and things like that. So we know that these are the high risk group that we need to reach. However, the graph below, you can see that this is a retention, not really adherence. The retention rate, we're not doing very well, and we have to admit so. It's not at our satisfactory level. So the data suggests that the retention rate among MSM at month 12, we have been able to retain them less than 50%. And for TG population, it's even less so. It's 25.3%. So things must be done and must be done very quickly. So in terms of scaling up in Thailand, so from the project Princess PrEP that I've been talking about, you can see the gray, the graph that represents the major contribution to the country scale up of PrEP. That is about more than 2,500 cases, accounting more than 50% of that, the national uptake. There are other initiatives combined altogether. We have covered less than 6,000 people in Thailand. And from the recent projection, we anticipate that the number that need PrEP will be about 200,000 people. 200,000 MSM and TG that require PrEP. So we are at 2.5%. Yeah. So this is not enough for scaling up, and this is certainly not enough for addressing epidemic among these key populations. So what we have done in our capacity while waiting for policy to be firmed up and national coverage in terms of health financing will be finalized. What we have done under the USAID linkages and Thai Red Cross is that we try to improve PrEP scale up under the patronage, because we have a limited number of drugs, limited quantity of drugs that can be provided. We have intensified demand creation strategy using any social media platforms you can imagine, through Twitter, through Facebook. And there are different segmentation subgroups in those platforms that only key populations, our MSM, our TG population, can reach them, can go to those chat room, sometimes engaging in some the same language and or pretending sometimes to have similar behavior so that they can engage and can try to bring them to the offline HIV testing services. So these have been the approach that, and the online approaches also include crowdsourcing, using crowdsourcing to generate interest among a more general public, hoping that we can try to find more MSM and TG in that population who are not coming out yet, but are interested in knowing more about PrEP services. And we have that. We're surprised to see that people living with HIV sometime, Dr. Nitya told me this morning, even people living with HIV now, they are asking for PrEP services. So people start to know more, but we need to let them know mass media campaign and things like that. We're expecting that, am I running out of time? That people need to know, because when we look at our program alone, we started in first year 2016 with about 200 cases receiving PrEP. It skyrocketed to 2,500 in a year and a half. So there are people who need these services. So another intervention is the HIV testing. So we use HIV screening, oral fluid I mentioned earlier, to bring people to testing. These, however, we need to ensure that confirmatory testing is available and is guaranteed that these people screened can be confirmed so that they can receive PrEP accordingly. So in conclusion, key population-led it is. Loud and clear. It provides us the rapid scale-up within our focus sites from 600 to 6,000, from 200 PrEP user to 2,500, so it's tenfold in our cohort. So this data then suggests that while we need to address epidemic control in key populations, it's the key populations that need to help to address this. And while we're waiting for this to be properly scaled up, we are also planning and to follow up with the national health securities in order to support the financing PrEP within the national health coverage, so that there's no cost barrier that can stop people, and people at poorer background can also have access to PrEP. So ongoing advocacy would need to be carried out, because until we have shared national targets that we need to reach, 200,000 altogether, and then we can try to achieve that together. So more demand creation is also needed for younger population because they are presenting higher incident in among the MSM and TG population. So lucky we are planning to launch the adolescent PrEP in I think in this year, and hopefully that in 2 years we can share the results with you. So with that, I would like to acknowledge the hard work of the USA linkages team, FHI 360 and Thai Red Cross AIDS Research Center, and our community partners, MSM and TG communities, who have been working very hard in the past many years, doing all kinds of HIV services across the cascade. Thank you very much.
Thank you very much. We're very proud. And we're glad that you've got your iPad returned. That's good news. So, okay, we're going to move to the next presenter. Luana Marin, she's going to talk about comparison of measures of adherence to HIV pre-exposure prophylaxis among men who have sex with men and transgender women, the result from the PrEP Brazil study.
Hi, good afternoon. First of all, I would like to thank the AIDS 2018 organizer for the inviting and the opportunity to share with you some of the findings of PrEP Brazil study. Being here today is also a particular challenge and a pleasure for me. So my aim today is to show the results from comparison of measures of adherence to HIV pre-exposure prophylaxis among men who have sex with men and transgender women, results from PrEP Brazil study. This is my disclosure. Well, over the past few years, studies have demonstrated that the use of Truvada by HIV-negative persons who are at risk to become infected can substantially diminish the risk to HIV transmission, and that the levels of protections are directly proportional to adherence. The studies has also highlighted the relationship between efficacy and adherence, demonstrating that adherence is critical for maximizing the effectiveness of PrEP for HIV prevention. In this way, accurate adherence measures are critical for interpretation PrEP trials and also may play an important role in monitoring PrEP use in clinical practice. So in this study, we examined the concordance between 3 adherence measures in relation to protective drug levels among participants at week 48 in PrEP Brazil study. PrEP Brazil was a multi-center open-label demonstration study assessing PrEP delivery for men who have sex with men and transgender women at higher risk for HIV infection in Brazilian public health system context. It was conducted at 3 reference centers for HIV prevention and care. 3 adherence measures were obtained at week 48. Pill count, the number of tablets dispensed in prior visit minus tablets returned at study visit divided by the days between the 2 visits. The interval of visits was 90 days. Self-report, in-person interview for a recall of 30 days, and medication possession ratio, the ratio of days covered by a dispensation relative to the total number of days between the 2 visits. The estimates of use, pill used by pill count assumed that all pills were taken from the returned bottles, and MPR values equal or greater than 1 indicates 100% coverage or higher, and NPR below 1 reflect days uncovered by study drug. Dried blood spots were collected for tenofovir diphosphate assessment from all participants, and tenofovir diphosphate was measured using liquid chromatography tandem mass spectrometry at the University of Colorado Antiviral Pharmacology Laboratory with standard procedures. Concentration of tenofovir diphosphate in dried blood spot reflects a dosing over to about 17 days. For the purpose of this analysis, we assumed as high adherent all those with tenofovir diphosphate concentration equal or greater than 700 femtomole per punch, which is consistent with 4 or more doses per week, and is considered as highly protective level. Area under the ROC curve was used to evaluate the accuracy in discriminating between those with or without protective drug levels. From ROC curve, the optimal cutoff for the adherence measures were obtained based on Youngden index and distance to corner. Negative and positive predictive values for those cutoff points were used to evaluate the concordance between achieving protective drug levels and the 3 adherence measures. And finally, the long test was used to evaluate whether the curves are different from each other. This is our results. 450 participants initiated PrEP use. Of those, 375 were retained to 48 weeks. 74% of the participants had high adherence based on drug levels at week 48. The median adherence was 1.1 for MPR, 97.1% for pill count, and 100% for self-report. The area under the ROC curves were 0.70 for MPR, 0.68 for pill count, and 0.65 for self-report, demonstrating that all the 3 adherence measures were able to discriminate between those with or without protective drug levels. Results from IPREX placebo-controlled trials showed that only MPR was able to discriminate between achieving or not protective drug level with poor discriminatory ability. We found a fair discriminatory ability. Results from other open-label studies conducted at resource-rich countries found discriminatory ability that varies from poor to good. The best cutoff points for the 3 adherence measures were 1.07 for MPR, 90.09% for pill count, and 99.90% for self-report. At these cutoff points, the concordance in terms of predictive positive values was 0.85 for MPR and also for self-report, and 0.86 for pill count. In practice, it means that for our population, there was 84% of probability of having high adherence based on drug levels for those with MPR equal or greater than 1.07, 86% of probability for having high adherence within those with pill count equal or greater than 90.09%, and 84% of probability of having high adherence for those with self-report equal or greater than 99.90%. On the other hand, low adherence according these 3 adherence measures were not predictive of not achieving protective drug levels. Negative positive value for MPR was 0.41, for pill count was 0.47, and for self-report it was 0.38. For example, there was 41% of probability of not achieving protective drug levels with those with MPR below cutoff point. The same pattern was found for the other adherence measures. And finally, there was no difference between the three adherence measures in the ability of discriminate those with or without protective drug levels. In summary, all adherence measures were able to discriminate between participants with or without protective drug levels. High recorded adherence was predictive of protective drug levels. On the other hand, low recorded adherence could not predict lack of protective drug levels. Low burden measurements such as MPR and self-report can be used to predict PrEP adherence in a public health context in Brazil. I would give my special thank for the study participants, PrEP Brazil study team, University of Colorado Antiviral Pharmacology Laboratory, and AIDS 2018 Scholarship, and also acknowledge the funds, the resources of our funds, CNPq, Secretaria de Vigilância Sanitária, FAPERJ, FAPESP, and Gilead Science.
Thank you very much, Ilona. Now we open to questions.
Hi.
Any questions? Yes, please.
Sorry. When you looked at the predictive value, and you were looking at drug levels, did you only look at the highest drug levels? Like, how did you dichotomize drug level, and then what was the split?
We dichotomized it. We dichotomized it. We analyzed only the
highest
cutoff. Yes.
And then this is kind of a little bit like Donald Trump. You had a double negative there, right? Because but so if you try to unpack that a bit, it means that self-report. I'm puzzled by the fact that self-report can predict whether you're on drug, but it doesn't predict whether you're not. I mean, it almost seems counterintuitive, and I wondered what your thoughts were there.
Yes. Some reports have some bias. So, I don't know. Self-report can, I agree, predict when you are at drugs. But there are some studies that show that when the patient says that I don't take the drugs, it's correct. And more correct than when he or she tells us, I am taking the drug.
Okay, thanks.
Okay. You're welcome.
Yeah, thank you very much, Etienne Kadima. I would like to address my question to the presenter from Thailand, the study.
Sorry, let's focus on this presentation.
On this presentation. Yeah. So my question was for
but
the
maybe
previous one.
You can ask the question after the session is over.
Okay, thank you.
I have a question, and I wondered, maybe I missed it in your presentation, but were there no treatment interruptions, if you like? I mean, it seemed a very motivated group who was religiously taking their PrEP, and they wanted to demonstrate that they actually could do that. But in real life, people may stop and then start again. And how do you account for that?
Yeah, we didn't assess this. In fact, we didn't assess this in this analysis. But yes, participants tend to use PrEP when they are at risk. And our measures have different times for assessing. For example, MPR is for 90 days and DBS for 70 days. I don't know. It's a study that maybe conducted, but we didn't did at this time.
So we thank you for the presentation. Thank you so much. So our next presenter is Gillian Pintai, a postdoc from the University of Washington. She will, title of her presentation is Uptake of PrEP within clinics providing integrated family planning and PrEP services. Results from a large implementation program in Kenya. Gillian.
Good afternoon, and thank you for attending our session. On behalf of my co-authors, I am pleased to present this abstract about PrEP uptake in an implementation program within routine family planning clinics in Kenya. There is an urgent need to prevent HIV in adolescent girls and young women. Within sub-Saharan Africa, young girls and women account for 74% of new infections among adolescents. And this group has a 2 to 8-fold higher risk of HIV acquisition than their male counterparts of the same age. 1,000 new HIV infections occur among young women in Africa each and every day. As HIV prevention programs targeting young women scale up in the region, routine care settings frequently accessed by young women could be leveraged as a platform for reaching this important high-risk group. Routine family planning clinics are particularly an attractive option for integrated PrEP delivery for several reasons. Family planning providers are uniquely positioned to counsel on and provide PrEP as they already counsel on sexual health, relationship climate, and other sensitive issues as topics part of existing reproductive health services. Sexually active women access family planning clinics and are routinely screened for sexual behavior, including HIV risk factors. PrEP screening could be integrated efficiently within this context to identify women at high risk for HIV. Family planning clinics also have systems for drug procurement, commodity management, and tracking patients, which could be leveraged for PrEP programs. And further, the WHO and several ministries of health recommend integrating family planning and HIV services to increase access to both, including provision of HIV testing and HIV prevention services into family planning clinics. However, to date, there are few examples of integrated PrEP delivery within family planning clinics in African settings. This leaves a number of important implementation science gaps. For example, will women recognize their HIV risk and accept PrEP when offered? Will preferences for methods of pregnancy and HIV prevention differ in this group? Will there be differences in PrEP use among women using different forms of contraceptives? And answering these questions will be important for optimizing PrEP within this setting. We sought to address some of these implementation science gaps through the PrEP Implementation for Young Women and Adolescent program, known as PREA. And PREA is a PrEP program that is part of the DREAMS Innovation Challenge program, funded by PrEPFAR, managed by JSI, and implemented by the University of Washington. PREA provides real-world evidence on delivering PrEP to young women integrated into routine maternal child health and family planning clinics in Kenya. And I'll be presenting findings from PREA today. PREA implements integrated PrEP delivery in Kisumu County, which borders Lake Victoria in western Kenya. And PREA is implemented in 16 sites across the county, which are displayed here. And today I will present results of an analysis which aims to evaluate PrEP acceptance and cofactors of uptake among women offered PrEP during routine visits at family planning clinics. We approached HIV uninfected women seeking routine family planning services at PREA's 16 sites. Women were tested for HIV prior to family planning services as part of routine care. And following receipt of HIV testing and family planning, HIV uninfected women were individually screened for behavioral risk factors and willingness to consider PrEP per Kenya National PrEP guidelines. Those who were willing to consider PrEP were assessed for medical eligibility, and those eligible were dispensed PrEP at the same visit by the same nurse within the family planning clinic. So there was no additional pharmacy pickup required. And to determine correlates of PrEP initiation, we use logistic regression models accounting for facility-level clustering. And the current analysis includes data collected from November 2017 to June 2018. In total, 1,122 women attending family planning visits were screened for behavioral risk factors and willingness to consider PrEP, of whom 21% initiated PrEP. The median age of women was 25 years, and most were married. 1/3 of women reported having a partner of unknown HIV status, and 4% had an HIV-infected partner. Over half of women used injectable contraceptive methods, and nearly 1/3 used implants. Less than 5% of women used each respective other family planning method, including oral contraceptive pills. To answer the question of who would initiate PrEP if offered, we evaluated PrEP uptake by a number of key characteristics. Overall, 21% of women who were screened initiated PrEP. And the frequency of PrEP initiation differed by male partner HIV status, with almost all women with an HIV-infected partner initiating PrEP, and about 1/3 of women who had a partner of unknown HIV status initiated PrEP. PrEP initiation was more frequent among women older than 24 years than younger women, and among unmarried women compared to married women. To answer whether uptake of PrEP differs by contraceptive method used, we stratified frequency of PrEP uptake by method. Frequency of PrEP uptake was lowest among injectable contraceptive users at 17%. However, injectable users were the largest group of women offered PrEP, comprising over half of the overall population. Therefore, in absolute numbers, injectable users were the largest group of PrEP initiators. Frequency of PrEP uptake was highest among oral contraceptive pill users at 30%, though fewer women used pills as contraceptive method. And uptake was similar among implant users and other methods, though the number of women using these other methods was relatively small. We also evaluated whether women with HIV risk factors were more likely to initiate PrEP. And here the asterisks indicate the level of statistical significance. Initiating PrEP was associated with behavioral risk factors such as having been diagnosed with an STI, being forced to have sex, experiencing intimate partner violence in the last 6 months, and having a partner of unknown HIV status. Women were also more likely to initiate PrEP if they were older than 24 years. Condom use was not associated with PrEP uptake. And women using oral contraceptive pills were nearly twice as likely to initiate PrEP as women using long-acting methods of family planning. Among women who had risk factors for HIV but declined PrEP, the most frequently reported reasons for declining were needing to consult partners and low perceived HIV risk. Nearly 1/4 of women reported pill burden as a reason for declining PrEP, and few women declining PrEP feared intimate partner violence as a result and side effects. In summary, approximately 1/5 of women attending routine family planning visits initiated PrEP in this large implementation program. PrEP initiators were more likely to have HIV risk factors than women who declined, and adolescents were also less likely to initiate. Oral contraceptive pill users were more likely to uptake PrEP than women using long-acting methods, and pill burden was a frequently reported reason for declining PrEP. These findings are important for guiding new directions for PrEP agents and delivery. that respond to the needs of women for whom a daily pill may not be acceptable. Our findings support that family planning clinics could be an important access point for women in high HIV burden settings, and innovations are needed to increase PrEP acceptance in this group, particularly among injectable and long-acting contraceptive users. And we also need to address barriers to PrEP among adolescents accessing family planning clinics who are known to have risk factors for HIV and are sexually active. Tomorrow, Dr. John Kanuthia is here in the audience. Will present findings from PREA on uptake of PrEP among pregnant and postpartum women within routine maternal child health clinics. And I encourage you to join in that discussion if you're interested in integrated PrEP delivery. Hold on, I had one more comment. Just that we thank all of our participants and collaborators and staff, and a special thanks to our funder, the Dreams Innovation Challenge, and to JSI. Okay, now you can clap.
This paper is now open for questions. Please.
Thank you for a great talk. I was really interested in the tenfold increased odds of uptake given an STI, and my question is was that ever STI or STI at that visit? Because it kind of parses out whether that's about just past risk behavior or whether being diagnosed with an STI at that visit increases your sort of awareness of vulnerability to HIV.
Yes, great question, and thanks for giving me the opportunity to clarify. So that question is really that an STI diagnosis or treated for an STI in the last 6 months, and this is directly from the National AIDS and STI Control Program's screening tool. That's a Kenya Ministry of Health document that is the behavioral risk assessment that is provided to clients being screened for PrEP. So it's within the last 6 months.
Thank you.
Thanks, Gillian. Brilliant presentation. I wanted you to say a little bit more about the women who had negative partners and yet opted for PrEP. What was their motivation? What are some of the things they're thinking about? And then also, what is special about OC, the oral contraceptive users? Why is it that they find it much easier to uptake PrEP? Thanks.
Yeah, great questions. And so anecdotally, why we hear that women who report having a negative partner initiate PrEP is that perhaps they don't trust the partner. Also within this context of Western Kenya, we have a sizable proportion of women that are in polygamous marriages, and sometimes they either know that a co-wife is HIV positive or they don't trust her. And so there's several relationship reasons that have been communicated to our nurses. Your second question about the OCP users, we are looking at that now and have more planned qualitative studies to really delve into that more. But what we hypothesize is that if it's easy for a person to take one pill every day, then it's easy for them to take another pill every day. Whereas perhaps women that are using injectables or long-acting methods that don't want to think about a pill, or that was their motivation for using a non-pill method, may not be as interested in a daily pill.
Microphone to the left, please.
Thanks. That was a fantastic talk. Barbara Friedland from the Population Council. So I just wanted to follow up on the question about the behavioral risk factors. So I believe you said that it's from the Kenyan government. So is it like a short questionnaire? Do the women do it themselves, or is it something in the context of counseling? How do they make that assessment? Thanks.
Sure, and just to qualify this, it's evolved over time and is still under development what that tool looks like and how it's administered. But for the purposes of PREA, how we've administered it is a quick questionnaire. It takes about 1 to 3 minutes, what we found in time and motion studies to conduct. Our nurses conduct this, so it's a nurse-administered questionnaire that's really intended to guide counseling and inform what messaging the nurses will provide the woman. And the standard panel of questions are, I think there's 10, and they ask about male partner status, condom use, transactional sex, IPV, intravenous drug use, and I think recurrent PrEP use is the last one, and STI diagnosis. So kind of a standard panel of HIV behavioral risks.
Laura?
Hi, Gillian. Thank you for a great presentation. You said in your conclusion what my question was kind of preempting about adolescents being a lower uptake. My work is a lot with youth and adolescent and youth-friendly settings. So I wanted to know a bit more about the health workers and the ANC workers and the FP providers. Are they youth? Are they youth-friendly? Do you have any idea about whether that caused the lower uptake?
Yeah, great question. And we actually have an entire other project that is specifically looking at the influence of healthcare workers and how that group can be utilized to improve PrEP uptake and continuation. What we've heard, again, this is more anecdotally, the qualitative work is ongoing, is that it helps if the nurse looks like them, looks like the adolescents, and is young and comfortable talking about sex, and that seems to improve the relationship and the rapport.
Final question by men.
Okay. Dustin Duncan from NYU. I was really intrigued by your finding about IPV and PrEP uptake. In my initiation, my question was about what type of IPV was analyzed, and if you thought about disaggregating by types of IPV.
Yeah, that's
and
another
perhaps I missed
great
that
question.
in your talk, yeah.
So I didn't disaggregate here or mention this, but one of the questions on that screening tool is very simply, have you experienced IPV? So it's not a validated tool like the HITS or other scales. Okay. What we've added on through our learning and realizing that we really could improve that variable is asking about what type of IPV, and so looking at physical, verbal, withholding resources. We haven't looked at it yet in this data, so I can't comment on that, but in the future we will be able to disaggregate by those larger groups. And then additional studies that we have going on are using the validated tools that other studies have used as well.
Thank you.
Gillian, one final short question.
I promised it would be fast. So just a quick question about the high uptake of PrEP among the injectable contraceptive users. Does that have anything to do with the kinds of counseling messages women were receiving about the uncertainty around a potential association between DMPA use and risk of HIV acquisition? I framed it as a yes-no question. So.
Oh, I can't give that a yes-no answer, though. I think that the communities where we work, there is some awareness of the potential increased risk that's associated with DMPA. I can't really comment on that specifically. That will probably come out in the qualitative work more richly, since we simply don't systematically capture that data as part of this programmatic work.
Okay. Thank you very much. Our next speaker is David Magnuson. David will talk about adolescent use of Truvada for HIV pre-exposure prophylaxis in the United States, and it's an analysis from 2012 to 2017. David.
All right, I want to thank everybody for sticking around, and for those of you who also came in at 7 this morning, I thank you for really sticking around. I want to thank the organizers for the opportunity to share this information. As disclosures, all of the authors are employees and shareholders of Gilead. As background information, I think everybody knows that FTC-TDF has been approved for PrEP in high-risk individuals sexually acquired HIV. It's been approved in the U.S., it's been approved in the European Union, and at least 19 other countries. In 2016, the CDC did an analysis, and they determined that over 37,000 new HIV infections occurred in the U.S., and of these, 21% were in individuals who were aged 13 to 24 years of age. In this age group, 81% of them were classified as young gay or bisexual men. There's limited data on the use of FTC-TDF for PrEP in adolescents in the United States. 2 studies have been done, one in the United States, and that's the ATN-113 study. It evaluated 79 men who had sex with men who were between the ages of 15 and 17. And they had demonstrated that there was good overall safety and acceptability, but there was a high HIV incidence and poor retention and care. The CHAMPS plus pill study done in South Africa evaluated 99 females and 49 males between the ages of 15 and 19. And they also demonstrated that PrEP was well tolerated, but that usage and adherence diminished over time. In the United States, some of the challenges that are faced in prescribing PrEP in adolescents include the stigma, the need for parental consent in some of the states, and it varies by the state, whether it's 18 or whether it's 15, so it varies by the state. In the U.S., for those of you not from the U.S., insurance is not automatically guaranteed, and there are unfortunately people that lack insurance coverage. If parents are able to have insurance, then there's the possibility that when the PrEP prescription is written, that the parents are going to find out about it through their insurance statements. Then there's also the difficulties in adherence with a high rate of discontinuation compared to older adults. We have received FDA and EU approval for adolescents weighing at least 35 kilograms in the EU. That occurred on February 5th of this year, and in the United States, it was on May 15th. The purposes of this evaluation are to describe the real-world use of PrEP in adolescents, and for this study, we're going to be looking at the age ranges of 12 to 24. And we're going to look at a 6-year time period from January 2012 through December 2017. We're also going to evaluate the differences in the demographics, the treating physicians, and the payment source. The data that we used came from a national electronic pharmacy claims database that collected data from over 80% of the U.S. retail pharmacies. All of the data was de-identified. We had no idea who was actually taking PrEP. It included prescription refill data, medical claims, and procedures, and the demographic information was limited to just age and sex. And it also included prescriber specialty. We used a validated algorithm to identify those taking PrEP by excluding those who had HIV diagnoses or taking other products for HIV treatment, for those who had codes consistent with post-exposure prophylaxis or PEP, and for the off-label use of chronic hepatitis B. This first result slide shows the individual starting PrEP by the calendar year from 2012 through 2017. If you look first at the gray bars, these are for individuals 25 and older. And they account overall for about 85% of the usage over this 6-year time period. The adolescent group, 12 to 24-year-old, in the red bars, account for about 15.4% over this time period. And if you'll see the numbers in the line here, that the proportion each year stays relatively constant. We don't have an explanation as to why there was a slight little dip here. And also why I put in a period instead of a comma. But that's a minor point. If we break out then the adolescents, the 12 to 24-year-olds, and look at their usage over the same 6-year time period. Draw your attention first to the red slashed bars here, and those are the 18 to 24-year-olds. They account overall for 90.5% in this group. The 12 to 17-year-olds, 9.5%. One thing to point out is that within the past couple of years, the proportion of the 12 to 17-year-olds has dropped down. We don't have any explanation for that. So it has gone down a little bit in that age group. This graph compares adolescent males and females starting PrEP, and the x-axis is the year of, or the age year, not the calendar year, the age year. If you look at 18 and under, it is predominantly females. If you look over 18, it is predominantly males. The absolute number here has been increasing as the groups get older, but 12-year-olds and 13-year-olds, there are a small number, but there are some prescriptions written for that age group. This slide compares the prescribers that are associated with the prescription. And look first at the age greater than 25, the adults. The predominant prescribers are family practice and internal medicine. Compare that then to the 12 to 17-year-olds. The predominant prescriber group, as you would anticipate, are the pediatricians. I point out also the dark blue bar here is the emergency medicine physicians. That does decrease over time, and in all of these groups, there's more females than males getting prescriptions in an emergency setting. In looking at the payment methods, one thing to point out, the light green here, this is Medicaid. So for the 12 to 17-year-old, over half are getting their prescription supported by Medicaid, and that decreases over time. And as you would expect, that when individuals age and they become part of the working force in the United States, then commercial insurance becomes a major source for them. There are limitations to this analysis. The claims data only indicates when a prescription was filled, and it does not give us any information if the person took the medication. Claims data does not contain the dosing information or the SIG on the prescription. So we cannot evaluate whether these prescriptions were written for daily dosing or for on-demand or other dosing regimens. The claims data is limited, and it does not contain information on race or ethnicity. It does not contain information on the risk factors, so we have no idea as far as the circumstances leading up to that prescription, and unfortunately we cannot assess transgender status. The claims data does not contain data from non-retail sources, such as closed healthcare systems, such as Kaiser and other HMOs. The Veterans Administration, colleges and universities, where, for example, the Student Health Clinic, we unfortunately do not have access to that. And we don't have access to active duty medical health care centers. In conclusion, this was a retrospective analysis in which revealed that in people less than 24, that overall, in the 6-year time period, they accounted for 15.4% of the PrEP usage. And individuals less than 18 accounted for only 1.5% of the PrEP usage. For those less than 18, females accounted for 83.5% of the usage, and then after 18, it became male predominant, and the 18 to 24 was 84% males. As you would probably anticipate, that in the adolescents less than 18, pediatricians were the most common prescribers. The recent approval in the US and the EU to expand the indication for HIV PrEP to include adolescents more than 35 kilograms may improve access to PrEP for adolescents. And there remains an important unmet need to improve awareness and engagement in HIV prevention for adolescents and young adults at risk for HIV. And I want to thank all the young people and healthcare providers who contributed data. Thank you.
Thank you very much. This presentation is now open for questions. first.
Hi, David. Nice presentation. Bill Kapagianis from the National Institutes of Health. I'm curious about the, as you pointed out, the trend in the 15 to 17-year-olds sort of dropping off from that period of 2012 to 14 or whatever, and then kind of, I wonder if there's any information on by state, maybe the locales where the campaigns were going on for the ATN studies at that time.
We did a very preliminary analysis looking at regions and didn't really see any difference in regions. We did not look at it by year to go and try to explain that. But it's a good question. Thank you.
Hi, Viraj Patel from New York City. Thanks for sharing that data. It's really important, and struck by like the relatively low uptake. How do you think Gilead lowering its price might improve uptake and access? Because you talked about access to engagement and care, and that's being the primary, barrier.
Well, that's a fair question. I'm more on the science side and fairly low on the pecking order, so I'm afraid I cannot. Right. I can't really answer that.
Right, but you do represent Gilead today, so it's a social justice issue. But thanks for the response.
Thank you.
Yes. Thank you, David, for the presentation. Varuk Deda with CDC Caribbean Regional Office. Can you share insights into why prescriptions were made since 2012 when you mentioned a portion of the adolescents were approved to be included only in May of this year?
We started to monitor this in 2012 after the initial approval. And in fact, we actually had looked back a couple years, and there were prescriptions being written in 2011, 2010. So we feel that probably as research results were coming out, because Truvada was already on the market for the treatment, and in the U.S., although it is an off-label use, the physicians are not necessarily restricted. It's rather impressive that pediatricians, although they have not been a target for any educational efforts per se, because they haven't been part of this, they have been recognizing the important needs for PrEP. But
no conflict of interest.
Yeah.
Last question.
Hi, good afternoon. I'm Igor Mokoro, and I'm a nurse working with San Francisco Department of Public Health in San Francisco. And I'm really impressed with the presentation because it's hardly that we get information about adolescents and young adults. And how do we see that? I mean, do we expect any changes in terms of uptake of PrEP, particularly that FDA approved now the use of Truvada for those who are under 18? Although I tell you that we provide PrEP off-label regardless of their age, as long as they're 12 to 24 in our practice. But how do we see these changes? And at the same time, to follow up with the questions, is there any program from the Gilead to make PrEP accessible more to young people?
I can't really address the latter part. I do know, though, that as far as looking forward, certainly there are educational activities that will be getting started. As part of the approval process, there was educational material that has been mailed out to a lot of pediatricians. We actually created an educational brochure for the use of PrEP in this age population. I think as it becomes a general topic and there's more and more discussion, then it'd be nice to go and see that it's being considered more.
A follow-up question to that: are we in? Oh, sorry.
Okay, thank you. We're running out of time. Is there a real short question?
A really short. I'm Rachel Bagley from WHO. We're very, very pleased to see that PrEP is being used in younger age groups, but I'm slightly concerned at the very lower age group, the 12-year-old girls predominantly, and we would be worried about social protection issues of 12-year-olds being prescribed PrEP by a physician. And I'm just wondering, how long were these PrEP prescriptions before, and how can you be certain they weren't for example, for PrEP, and somebody was using a 2-drug PrEP regime for the various, to reduce adverse events?
Well, that's a good question. The algorithm in which we used, if there would have been another antiretroviral prescribed, then the individual would have been excluded for that reason, or if there would have been any of the billing codes that are commonly used in PrEP. Unfortunately, PrEP can be hard to go and find. But I think we have evaluated and are fairly confident that there aren't very many PrEP uses there.
Okay, thank you very much. Our final speaker is a late-breaker presentation by Makita Margaret Kombe from she will talk on the integrating oral HIV pre-exposure prophylaxis in a public family planning facility and youth center to inform national rollout in Zimbabwe. Makita is an economist and she's with the Clinton Health Foundation.
Okay, so I'm here to tell you the story of wanting to integrate PrEP into the public sector so that everybody who is at risk in the general population can access it. So the Ministry of Health spearheaded this, and they wanted, primarily for reasons already mentioned, to put this in a family planning facility and a youth center in order to catch the younger people. So the 2 locations, one is in Harare, Urban Family Planning Clinic, a lot of HIV negative tests. They serve various neighborhoods, and their clients are mainly women seeking contraceptive services and men seeking VMMC. And then a rural youth center in Chimanimani near the border of Mozambique. Also a lot of HIV negative tests, a vibrant small economy with banana plantations, gold panning. Men occasionally travel to South Africa for work. And the chiefs there are very influential in their community. So in order to start this, we actually had to speak to the chiefs, and then they cascaded the information down to their community members. And the objectives of this was 2-pronged. Firstly, the facility, what was needed in order to integrate PrEP into the facility. So PrEP uptake, healthcare worker awareness and readiness, and then the client experience, actually following up the clients who took up PrEP. Why did they take up PrEP? Did they adhere? Why did they come back? And the data collection for the facility, we collected information on who took up PrEP and HIV testing figures, and then interviewed the healthcare workers. And then for the client experience, we had 60 semi-structured interviews, which were transcribed and then analyzed. So for the implementation, the healthcare workers went through 2-week ART training because the healthcare workers had not already been giving ART, and then they went through a 1-day PrEP training to put PrEP into perspective into the greater ARV regimen, and then the M&E, how they would record when PrEP was integrated. And then what the healthcare workers then did was included PrEP into the daily group education. So whatever a client was there for, they would talk about PrEP, and then they would then send them for HIV testing if they seemed interested, and then they would continue the conversation about PrEP, and after clinical assessment would give them a 1-month supply and then 3-month supplies going forward. And the risk assessment was mainly, as was mentioned earlier, in the past 6 months, how many people did you have sex with? Did you use a condom every time you had sex? And have you had a sexually transmitted infection? And then with regards to your partner, does your partner have HIV? Yes, no, don't know. If yes, are they on ART? And if they are on ART, do you know if they are virally suppressed? So these were some of the questions that were asked to people in order to assess their risk. And what we found was that in the rural Chimanimani site, there was much higher uptake than in the urban Harare site, which was shocking for us. But overall, there was a 4.8% uptake of PrEP. There is something missing here. I have to put the disclaimer. The orange bar are total HIV tests that were conducted. We are missing a bar of who that was HIV negative was actually found to be at risk. The healthcare workers had been asked to fill this in, but I think they mentioned that copious amounts of documentation that needed to be done, they skipped that part and just documented HIV testing and who took up PrEP. So there is a gap missing there. And the majority of clients who took up PrEP did not know their partner's status or were in new or known serodiscordant relationships. So what the healthcare workers then said was it was very important. They found that it was very important to understand the client's motivation for taking up PrEP, because it was a key determinant on taking up and then continuation. To capacitate as many healthcare workers as possible, because initially there were a few healthcare workers that had been trained. So if somebody then wanted to take PrEP, they had to be sent to the PrEP nurse, which then meant establishing a new rapport with a different nurse. And then to also minimize documentation required for PrEP. They said the amount of documentation was copious, which is why some of the information was missing from this. And then initially the risk assessment was just about the client, but they said that we needed to add a component of the partner's risk assessment, because a lot of the people who took up PrEP was because of their partner's risky behavior or their partner's statuses. And then moving on to the client experiences. Talking about why they declined PrEP. Similar to the Kenyan study, they needed to ask their partners for permission. So that is a quote from a 20-year-old who said that if she decided to take it, then her husband would assume that she's the one who's engaging in risky behavior, even though she's the one who suspects her husband of being risky. Others are satisfied with their current method. I was told about PrEP, but condoms are really good. Fear of pill burden, as was mentioned. This person says even taking a painkiller if they are unwell is difficult for them, so they don't want to take PrEP. And their motivators for accepting PrEP, the high risk perception is mentioned, so which is why we had a lot of people who mentioned either being in a serodiscordant couple, or a lot of the women would detail that their husbands are either in migratory employment, such that every time they come home, they suspect that their husbands bring them STIs. Some of that information came out. And the desire for a different HIV prevention, you found a lot of people mentioning if condom bursts, then at least I have a backup method. And then the perceived benefits of PrEP. I am protected. I always wanted to have a baby. We could never do it. We went to the doctor, but now at least I'm taking PrEP so we can try and conceive. And this was both in males and in females. And then the barriers to adherence and retention. The size of the pill was mentioned. As you can tell from that quote as well. There were counseling issues. So the Zimbabwe guidance is take PrEP for 7 days before exposure and then continue taking after. We had a few people who would take for 7 days before exposure and then stop, and then take for another 7 days before different anticipated exposure. And then limited access. Some people actually didn't have enough money to go back to the facility. So PrEP in this instance was free, but they couldn't get 50 cents or $1 to go back to the facility to collect some more. And then lack of partner support. Some took it for the first month, and then their husbands found the pills, threw away the pills, threatened violence, or told them not to continue. Then forgetting to take medication if using alcohol. And then facilitators. It's mainly the reverse of what I just mentioned, but routine. Some people established a routine, taking family planning pills at the same time as PrEP, or putting your PrEP pills on your nightstand or under your pillow, such that when you go to bed, you can take your pills. Partner support, especially for serodiscordant partnerships. When he takes his ARVs or when she takes her ARVs, I'll also take my PrEP. Continued high-risk perception. You have some people who actually arrived early for the appointments because they didn't want to make the mistake of running out of pills, because they say that PrEP was their lifeline, and then planning ahead before travel. If they knew they had to be somewhere, go early for your appointment. And then some nurses were really working with the clients to try and get them to adhere. Questions. As a new thing that had just come in, a lot of clients had questions. Is there a time when PrEP will be saturated in my body such that I don't need to continue to take it? Is it safe to take PrEP with other medicines, whether it be STI treatment or birth control for those who didn't know, or other drugs at the same time? And HIV prevention methods. Now that I'm protected on PrEP, do I need to continue to use other HIV prevention methods? And if I happen to miss a pill or two, how do I continue to be protected? Is this sustainable? You've said that it's a study. Will there be more PrEP coming? And exactly how effective is this? And then, like anything new, there were community misconceptions. Some people believe that PrEP is only for women. So she took it under the guise of, yes, it's only for us women. Current PrEP programs are a trial and we're being experimented on. So this might not actually be working. And then you have, PrEP can make you sick or diminish your immune system, such that at some point when I go for HIV testing, HIV will actually be detected in my blood. So the key lessons and conclusions from this are that risk perception is a key driver of PrEP. So we didn't find a lot of the other key populations, but it was mainly serodiscordant couples and women who are married in stable relationships but suspect their partners of being unfaithful. So a lot of the recommendations that came from these were informational meetings or spokespeople and outreach materials can help other people know about PrEP. Partner and family support was also very important. A lot of people managed to adhere, to retain, because their partners urged them on to keep going, or their family. And then to also keep stressing that PrEP is not for life and should be used with other prevention methods. And so far, all the findings from this have been used to inform the Zimbabwe National PrEP Implementation Plan, the Healthcare Worker Training Manual. We have a PrEP music jingle for demand generation, and we have an HIV prevention, treatment, and care communication strategy that is currently being developed. And I would like to acknowledge our funders and the participants and the data collectors that assisted in the study. Thank you.
Thank you very much for a very nice presentation. Open for questions.
Hi, Ariane van der Straten, RTI International. Thank you for this very nice presentation. You mentioned misconception and rumors about PrEP, which is sort of inevitable with a new technology being rolled out. I was wondering what your program is doing to counteract or address some of these misconceptions to avoid them spreading wider in the community. Thank you.
Do I answer it now?
Yeah, please.
Okay. So this is what I alluded to, the communication strategy that is being developed now. It is trying to preempt all these. So even the PrEP jingle that was created for the PrEP national launch, it also spoke about being inclusive, so not just women, like men and women, and then trying to encourage people to go and speak more to healthcare workers so that they can get more information.
Which channels of communications are you using?
So the strategy only is being developed now, so we haven't actually gone down to all of that.
Okay, we go to
Thanks for an excellent presentation. My name's Kimberly Green and I'm with PATH. And it struck me when you were talking about the challenges related to transportation, that PrEP is free, but that the women aren't able to come back to the facility in some cases to pick it up. And Zimbabwe championed the CAGs, or the community ART groups. And I wonder if you're thinking about some kind of a similar approach, either integrating PrEP into those groups or setting up separate groups, so that those that are on PrEP and stable could pick up PrEP in the community rather than having to come to the facility.
Okay, so I'm not best poised to answer that, but I'm going to ask my colleague within the Ministry of Health to assist.
Could you come to a microphone?
Sorry. On that question which you asked about whether we want to use the DSDs for the PrEP, like we said, we just launched our PrEP strategy and we are coming up with communication challenges. And as a country, we are aware of our DSDs as services which we are using for our cards. And we are looking at, with our communication strategy, those are the areas which we look at to say for peer support and all that for the PrEP, and how we can use the cards and all those people actually to assist. But we haven't come into as she had said, the strategy, I think we are developing, we started 2 weeks ago, and we are yet we are using actually the human-centered design. We are yet actually to get information, more information, and come up with those key messages and how we can support the delivery of PrEP to those who cannot come to the care facilities.
Great, thanks.
Okay, we have two more questions.
Nancy Padian from Berkeley. So very quickly, I was unclear on how much of the data were longitudinal, because you looked at retention and you said that some people didn't take after 7 days, but then I wasn't sure for how long you followed them to look at retention. And also, could you speculate about the rural versus urban differences?
Okay, so we followed them up for the ones who accepted PrEP. We followed them up after their first appointment, so whether or not they missed or attended their first appointment, and then after their second appointment, which was 4 months after initiation and 3 months after the first appointment.
Got it.
Right. So whether or not they attended or missed their second appointment as well, we followed them up.
Thanks.
Right.
And urban, yeah.
And then the urban versus rural, as I mentioned, that the rural site had the chiefs involved, and they went and cascaded it to their community members. So already you had community members coming to the facility saying that the chief has said this. And the chiefs themselves had already wanted to address the gatekeepers when we did the initial launch. So they spoke to the parents, they spoke to the spouses. So by the time rollout happened, we already, I think almost those barriers had been pulled down.
That's great. Thank you.
Last question.
Thanks for a terrific study, Renzo Shearer from Chicago. I wonder if you could talk a little more about the jingle and how it was developed, and did you use radio to disseminate the message? And then there's a lot of interest in crowdsourcing, using social media or the web to actually gain community engagement in such a thing as developing a song or the dynamics of the program. So I wondered if that was part of this. Just a little more on the song.
So it was. I will start with just the feedback from the study. A lot of demand generation for health programs in Zimbabwe has been done by artists, famous artists. So even in the study, when we asked the participants, how do you think PrEP uptake can be improved? They said themselves, like you did for VMMC, can we have a song from somebody that we recognize? So we got the idea from the participants themselves. And then we got a lot of just information from the interviews, so like misconceptions or what people thought worked really well or a thing that they remembered. And then my colleague and I, like while driving from one of the sites, were coming up with key messages that we sent to the artist, and then he came up with the jingle. So it's a well-known song that he used that resonates with everyone, just the message is talking about PrEP.
Yes, no?
Very short, very last.
Okay.
Then.
Thank you very much. My name is Rabia Rosenkamp from the Fred Hutchinson Cancer Research Center. In terms of like the PrEP conversation, I just wanted to touch on sort of like better estimating like when someone's been infected. So when we're talking about figuring out that someone's HIV negative before putting them on PrEP, we obviously wouldn't do like a viral load test, but if they are in the window period, there is a chance that we would be putting them on like a 2-drug treatment regimen, which would suppress their viral load and possibly delay when you'd be able to detect. So it's just something to think about.
Okay, I think we can all think about it. I think we like to thank all the speakers. I'd like to thank my co-chair, and a big applause for a very good session.